Hello, and welcome to the Duke Cardiology Conference. I'm Sunil V, Assistant Professor of Medicine here at Duke University Medical Center. Today's program is titled Interventional Management of Thrombotic Risk in Atrial Fibrillation, and our distinguished guest is Dr. David Holmes, Professor of Medicine at the Mayo Clinic in Rochester, Minnesota. Dr. Holmes, thanks so much for joining us.
Sunil, it's great to be here.
So, Dr. Holmes, the other day we were rounding on the inpatient service on a 74-year-old lady who was admitted to the hospital with a CHF exacerbation. She has left ventricular dysfunction, and she was also noted to be in atrial fibrillation with a rapid ventricular rate. Now, we instituted the usual standard therapies. We anticoagulated her, tried to get her rate under control. But as you know, it can be very difficult in these patients. And part of the discussion that came up on rounds is what's new in atrial fibrillation in terms of anticoagulant management, in terms of potentially interventional management of atrial fibrillation thrombotic risk. What can you tell us about that?
Sure. Well, it's great to be here. The first thing is, what was her CHADS-2 score?
So her CHADS-2 score was quite high. It was about 4.
Okay. Does that make a difference?
You know, we think that it makes a difference. Certainly, it would push us to anticoagulate her. But oftentimes, these patients are also at risk for falls, and they're at risk for subsequent procedures where the warfarin has to be interrupted. It can be difficult to regulate warfarin. So certainly, I think there's a need to have newer options.
Good. Well, that's a tremendous lead-in with a case like this that brings up a lot of interesting points as we talk about that. I do have this following relationship to disclose in terms of some technology that Mayo and I share with the company that is involved with the device that we will be talking about in part. How big is the problem of this 74-year-old woman? If you were to look at it, atrial fibrillation is the most common arrhythmia, as you know. The lifetime risk, this is an extraordinary piece of information. The lifetime risk of people over the age of 40, which I'm one of those people, is 1 in 4. So it's an extraordinarily frequent event. The second part of that is that those patients with atrial fibrillation, as you have mentioned, have a much higher increased incidence of stroke. And we can see that 87% of the strokes are thromboembolic. So in a case like this, when you mention the issue of thrombotic risk and stroke, it's a huge issue. There are a couple of things that are very important. In terms of stroke and atrial fibrillation, it doesn't matter whether it's paroxysmal, persistent, or permanent atrial fibrillation. That all results in the same increased incidence of ischemic stroke. The second piece of information is the older that you and I get, the increased incidence of atrial fibrillation and the increased incidence of stroke. The bottom line, in the old Framingham study, the risk of ischemic stroke that's attributable to atrial fibrillation, if you're really young, that is to say you're about 50, your chance of stroke that is attributable to atrial fibrillation is only about 1.5 or 2%. If you're 80 or above, the risk of stroke attributable to atrial fibrillation is about 25%. It's a huge issue. And this just gives the information on that age-related dependency on non-valvular atrial fibrillation and the percentage of stroke. As patients get older, as we get older, our risk of stroke attributable to atrial fibrillation clearly increases. This is a tremendous slide. It comes from Circulation. It was one of those images in medicine. As you can see from the title of it, disappearing left atrial appendage thrombus resulting in stroke. We can see panel A, the left atrial appendage, there's a thrombus. Panel B, that thrombus is moving from here to here, as it does there. Panel C moves out. Panel D, right during the study, the patient then develops a stroke. Extraordinary, interesting set of images, and that's what this is all based upon. As we think about it, as we think about the issue of strokes and atrial fibrillation, this is old data, but it gives you a sense of the functional impact of atrial fibrillation strokes. We can see that by virtue of the fact that the left atrial appendage is a big structure, relatively, and thrombus is big in the left atrial appendage, we can see that about 30% of the cases have a severe neurologic deficit. About 30% it's fatal. And oftentimes in those patients in whom it's not fatal, they wish it had been fatal, just because it is such a disabling large stroke. This is what it looks like in real time. We're called from the echocardiographic laboratory, and we can see that in the left atrial appendage there are a couple of very large thrombi that are very mobile. And so as we were to see patients like this, the potential for one of those or both of those to move and go north is catastrophic in terms of the size of what happens after it has moved and gone north. What do we know about it? In your case, you talked about then this 74-year-old woman that you were going to anticoagulate her. This is information about the fact that indeed warfarin is the cornerstone of therapy. This is a study from a couple of years ago that assumed 51 ischemic strokes per 1,000 patient years. If you were to use adjusted standard dose warfarin, and it sounds like you were going to do that in this 74-year-old woman, you prevented 28 strokes. The problem is, in preventing 28 strokes, there were 11 fatal bleeds. And so your thought in this 74-year-old woman of balancing the risk and the benefit ratio is a substantially important one, and we will then talk about some of that data. What do we know about the long-term treatment when we start patients on warfarin? So this patient, 74, comes into the hospital, heart failure, atrial fibrillation. You're going to now start her on warfarin. She has been, we're going to assume, warfarin naive. Hasn't been on it before. There's about 4,500, 4,400 patients who were newly started on warfarin. 28% discontinue it. At a year, if you start on warfarin with somebody, about a third of the time, the end of a year, they are no longer on it. That group of patients in whom you discontinue the warfarin, they have more major hemorrhage. They have higher variability in terms of their INR control. So it's a huge issue, and we can identify patients that are going to have problems. As part of that, you use the CHADS-2 score as seen here. There are a whole host of other risk scores. We can see the SPAF score, the Framingham score, the ACCP score, looking at patients who are at low risk for thromboembolism, intermediate risk for thromboembolism, high risk. If you take this 74-year-old woman, you'd like to say, I'm going to give you medication to prevent thromboembolism. You would like to have some assurity that indeed you identified somebody who was at risk for thromboembolism. This just looks at the annual rate of thromboembolism in low-risk patients and in intermediate-risk patients and in high-risk patients. And you can see that they track reasonably well these different scoring schemes. The higher risk, the higher the potential for thromboembolism. If you were to look at the percent of patients who did not develop thromboembolism compared to the group in patients in orange who did develop thromboembolism, you can see that it is sort of a crap shot. And you're not very good for the individual patient. And this is that incredibly interesting slide looking at sensitivity and specificity, looking at the group of patients in whom you do not have any information and these other risk scores. So as you see this 74-year-old woman and say, gosh, I think you're in trouble, are you going to be better off if you use one of the risk scores, or if you say, I don't know whether you're going to be in trouble or not? And so what did they conclude? Current risk schemes have comparable but only limited overall ability to predict thromboembolism. Limited ability to do that for the individual patient. We need better approaches for risk stratification in these patients so that we can improve the selection for anticoagulant therapy. This is a great slide of, happens to be a 74-year-old man, not a 74-year-old woman, but it relates to the fact that as the risk of stroke increases, as atrial fibrillation increases, we're then going to be concerned with an elderly group of patients. What do we know about warfarin use in elderly patients? This is data from a couple of years ago from Boston Medical Center looking at patients greater than the age of 65 who were newly started on warfarin. We can see about 60% of the time we're able to get a therapeutic INR. That's the data that's available, 60, 65%. We can see in this group of patients who were newly started out on warfarin, so they are warfarin naive, major hemorrhage occurs in 8%, intracerebral hemorrhage in 2.5%. And at the end of 1 year, that same recurring theme, 30% are going to be off warfarin in this group of patients, potentially at the most risk for benefiting from warfarin. The next piece of information is more recent, from 2009, looking at the ATRIA study of about 14,000 patients with non-valvular atrial fibrillation to look at the INR target. Terribly important. If we were to say the INR is an important goal, an important metric of therapy, let's look at that INR target. And this is what we know. If you were to look at INR, thromboembolism, and intracerebral hemorrhage, we can see that as the INR gets lower, as it drifts lower, because we don't want it to drift lower, but it does, thromboembolism increases. As the INR gets higher, intracranial hemorrhage increases. So for that same patient, over the course of his or her lifetime, as the INR varies, the risk of thromboembolism either increases or decreases. The risk of intracerebral hemorrhage either increases markedly or stabilizes. If we were to look at this older group of patients, at the net clinical benefit of warfarin events prevented per 100 patient years, we can see that the group of patients on the left here who are over the age of 85 benefit the most. Patients from 75 to 84 benefit very significantly. Younger patients don't benefit as much. But the bleeding problem is increased in that older group of patients. That has led to this graph that was seen in 1999 and is still the case. If you look at older patients, non-valvular atrial fibrillation, the use in patients with atrial fibrillation by age, the older the patient, the less frequently we're going to use it, and yet the more they need it. So the challenges are warfarin is not always well tolerated. Less than 50% of patients who are eligible are treated with it because of these issues. And if we treat patients with it, only about 2/3 of the time are they in a good range. And if it's above range, increased incidence of hemorrhagic stroke, which is often fatal. So that relates to this, which is a great slide, that indeed we use warfarin, which is a rat killer. That was where it was described. That led to the boxed warning, as you know, for warfarin in 2006 that said the label was strengthened to say that patients on warfarin are at risk for major and or fatal bleeding. And that has led then to the search for a new candidate. So as you think about this 74-year-old woman, you're going to think about what other alternatives are there. You're going to think about the use of aspirin. You're going to think about the use of Plavix or the combination. You're going to think about the Bigatran, and we'll talk a little bit about that, as well as other things that I either know nothing about and I can't pronounce them anyway.
Dr. Holmes, what's your opinion of the use of genetic testing for guiding warfarin dosing?
So at the ACC this year, the MEDCO study was released. It turned out the MEDCO study looked at genetic testing. The polymorphisms for variability in terms of warfarin are extraordinarily interesting. There are a couple of very common ones, and those common ones account for the majority of variability. We need to realize from taking care of patient standpoint, some patients are very well controlled with a Coumadin dose, a warfarin dose of 2 milligrams. Some take 7. That's all based upon genetic variability. That has been recommended by some that we use that. The problem is that even though it is available and you can get it, that it does not account for all of the variability that we see. So while the use of it can be associated with decreasing the need for subsequent rehospitalization, typically by decreasing bleeding, there is still a substantial number of patients, indeed, in whom they're going to be rehospitalized for increasing bleeding. It's a great question. I think that's coming. So let's get back to this patient. You might say maybe she falls under the category of the active trial. On this very busy slide, this was a trial that was published in Lancet in 2006. Patients who were at risk for atrial fibrillation-induced stroke, they were randomized to either oral anticoagulant therapy or clopidogrel and aspirin. So they could have either. So this 74-year-old woman would have been a candidate for the active trial. These were the number of patients. The average age was 70. Your patient was 74. Permanent atrial fibrillation was seen in about 70% of the case. A little unclear, so that wouldn't be your case, but that would be a very common situation. Somebody that has heart failure who's older, they may have permanent atrial fibrillation. This is what they found. Cumulative risk of the primary outcome in those patients who were treated with oral anticoagulant therapy in orange versus those patients treated with clopidogrel and aspirin. Those patients treated with oral anticoagulant therapy did better, for sure. They had less stroke, as well as the primary composite endpoint. So indeed, oral anticoagulant therapy, if it can be tolerated, it will work. Their conclusion was, clearly oral anticoagulant therapy is superior to clopidogrel plus aspirin in patients with atrial fibrillation and high risk of stroke. Happened to be particularly in those patients who were already taking oral anticoagulant therapy. The next thing is to say, well, there are problems with warfarin. I don't like to use it. My patients don't like it. How about new things? This is the RELY trial, dabigatran. You're familiar with that. It's not yet FDA approved. Perhaps it will be later this year or next year. But it's an interesting drug. It's, again, a prodrug. It is rapidly converted. We can see the half-life, and so the patients need to be on it twice a day. This was the RELY trial that was published in a group of patients who could be treated with warfarin. They were randomized to either warfarin or one of 2 doses of dabigatran. Primary efficacy endpoint was stroke or systemic embolism. Major bleeding was a safety outcome. This is the data. Dabigatran, as you look at this in either orange or in yellow, is associated with improved outcome compared to warfarin therapy for the prevention of stroke, systemic embolism. Clearly does work. The problem is we talked about the fact that 30% of patients in whom you start them on warfarin stop it. In this particular study, we can say that even more patients stopped dabigatran. So discontinuation of a drug that may be better than warfarin for preventing stroke is worse in terms of the fact that patients discontinue it in contrast to warfarin. The most important part of this is that if you were to look at major bleeding over 2.5 years, while with dabigatran there is less major bleeding, it is not zero. And there is absolutely no reason to think that at the end of 2.5 years that with dabigatran there will be no more bleeding. It's going to increase, albeit at a different slope. It's still going to increase. So what can we say about this new drug that people are incredibly interested in? More patients discontinue the new drug than warfarin. It's either non-inferior to warfarin or somewhat better than warfarin. Bleeding rates are going to increase over time.
Do we have a sense for why patients discontinued it, if there was comparable or perhaps less bleeding?
Great question. Dyspepsia was very common. However, that raises the issue with these patients are going to be on Plavix and other things. They're going to be given a proton pump inhibitor, and then there's concern that that won't be nearly as effective, but that was one of the most common reasons. Shortness of breath was another one. The final piece of information was that indeed myocardial infarction rates were increased. That was true with zymelagatran. In addition, you will remember.
Right.
No one knows exactly why that is the case, but they were clearly increased. This is the bottom line from Dr. Eugene Braunwald. He said, so far there is no free lunch. If you interfere with coagulation in any manner, it will be associated with excess bleeding. That has led then to the little boy with his finger in the hole in the dike, led to site-specific therapy. If you can identify indeed where the problem is, maybe you could just stick your finger in it, in that hole in the dike, and prevent any problems. And that is site-specific therapy of the Atritech Watchman device, where you identify the fact that most of the clot comes from the left atrial appendage in these patients. You then, if you can seal it off, you prevent any clot from moving, from developing in there and causing stroke. It's an incredibly fertile field. These are the players in it. There are even more since I made this slide just 2 weeks ago. There are now at least 8 companies involved in the development of site-specific therapy for occlusion of left atrial appendage. Some of them are surgical, some of them are interventional cardiology, some of them are interventional electrophysiology. It's an extraordinary field. This is the problem. Left atrial appendage, we can see the cast of the left atrial appendage. It's sort of like noses. There's lots of different kinds of noses. Some are sort of sharp and pointy. Some of them are broad-based. Some of them are not broad-based. And so we can see the left atrial appendage varies like sort of nose shapes. Some of them are very good for closure, as seen on the left, where there is a neck here, and you could put in a device and occlude that. Some of them have sort of the broad nose that wanders all over your face. They're going to have trouble with that because you're not going to be able to get a specific device in to occlude that. This is the information upon which the technology is based. If you were to look at thrombi location in the left atrium or the left atrial appendage, in patients with non-rheumatic atrial fibrillation, typically it's found in the left atrial appendage, 90%. Not true with valvular atrial fibrillation, but most of the patients that we see will have non-valvular atrial fibrillation. And so then this is the perspective for us to talk about. Can the left atrial appendage be occluded reliably? Does it work? Does it depend on the CHADS-2 score? You said the CHADS-2 score in the 74-year-old woman was 4 or 5. What about patients who cannot take anticoagulant therapy? There's only one piece of information. It's the PROTECT-AF trial. It's been published. It was a randomized trial of this new technology, the Watchman device versus long-term warfarin therapy. Non-inferiority study as seen here in terms of the Bayesian sequential design. And I'll present the analysis, the most recent analysis. It's important as we think about patients to identify which patients might have been candidates for the trial. These were the inclusion criteria: documented atrial fibrillation that could either be paroxysmal, persistent, or permanent. CHADS score at least 1, greater than or equal to 1, and it turns out that most of the patients were above that. There were key exclusion criteria. For example, if your patient had a prosthetic valve and was going to need warfarin anyway, no reason to use an occlusion device. So anybody that was going to need to be on it anyway. Anybody that can't take aspirin and Plavix, and so that's a different group of patients because you need to use aspirin and Plavix while the device endothelializes, and other exclusion criteria as can be seen here. As is true with any of these trials going forward, there are going to be primary efficacy endpoints, primary safety endpoints. The primary efficacy endpoint was all stroke, either ischemic or hemorrhagic, cardiovascular or unexplained death, systemic embolism. The primary safety endpoint was all of those things that go woof in the night, that wake you up. These were the baseline characteristics, very similar to your patient who was a woman. This was 30%. The average age was 72. She was 74. And we can see the other baseline breakdown, and they were similar. This is the CHADS-2 score data. If you were to say the patients at highest risk with the highest CHADS-2 score might benefit the most, this is the information that's available. We can see that a third of the patients roughly had CHADS-2 1 score. Your patient was in this category of perhaps 3 or 4, and that was about a quarter of the patients, as we might think about her specific risk. This is the data. 1,350 patient years, primary efficacy and intent to treat. Remember, it was a 2-to-1 randomization, 2 Watchman devices versus 1 control, and this was the rate. There was a relative risk or a rate ratio of 0.69, meaning that the group of patients who received the Watchman device had a 31% lower rate of the efficacy events in terms of a third less ischemic or hemorrhagic stroke, all-cause mortality, whether cardiac or non-cardiac, compared with the group of patients treated with warfarin alone. And you can see the confidence interval here in terms of that relative risk. This is what the Kaplan-Meier curve looks like. Watchman in orange, the control group in yellow. We can see that indeed over the course of time, out to now 1,500 patient years, the group of patients who are treated with the Watchman device have improved efficacy over the course of time compared to the group of patients treated with control alone. How about the specific components? This happens to be mortality, and we can see here there's a relative risk, 30% lower rate of death in the Watchman group. So it tracks the composite endpoint. So improved composite endpoint in terms of efficacy, improved safety in terms of mortality. It's a terribly important point because we will talk about that. And how about stroke? 22% lower rate of stroke in the Watchman group. So it is all concordant. The placement of a device like this indeed improves the outcome based upon the composite efficacy, based upon mortality, based upon stroke. This is one of my favorite slides. Now open even wider, Mr. Stevens. Just out of curiosity, we're going to see if we can also cram in this tennis ball. So you're going to say to me, Sunil, that the left atrial appendage is very fragile. Are there problems with trying to cram the tennis ball while you're seeing the dentist, the interventional cardiologist, or the interventional electrophysiologist? There clearly were. There was a safety endpoint, terribly important. Pericardial effusions, about 50% of the total device events. Terribly important because it is indeed a fragile structure. There were 22 of these pericardial effusions that were classified as serious. None of them resulted in death, but they were clearly rich emotional experiences. There was no question about that.
Did they occur early,
Early
versus late? So a little bit of a learning curve, perhaps.
Some of it's learning curve. They all occur immediately related to the procedure, though. Mm-hmm. They're not late sort of events, like is sometimes seen with some of the other devices that we put in. This is the primary safety signal, and we can see the number of rates in the Watchman device were increased compared to the control group. Primary safety rate was 6.2 events in the Watchman group versus 3.9 events. There comes with an increased upfront risk of safety in this group of patients. And we can see that it's early on. It occurs the day of the procedure, as would be true, and you could imagine would be true with patients undergoing an invasive procedure. Their early risks might be very different than if you just give them a prescription and say, go to the drugstore, fill it, start it tomorrow. There is clearly information on the learning curve as well as the technologies improved. And so in answer to your question about can it be better, can it be better if we have more experience or better devices, there is a continued access registry, patients meeting selection for the PROTECT AF trial. Now it's about 400 patients and the data hasn't changed. In the PROTECT AF trial, we remember pericardial effusion was seen in 5 or 6% of the patients. In this registry of close to 400 patients, pericardial effusion rate is down to 2.4%. Is it going to get lower than that? Probably. Is it going to be zero? Certainly not. We can see the periprocedural stroke is much less. It was seen in 1% of the PROTECT AF trial related to air embolization. As we got better and better at that, that then went away. Final pieces of information is to say, does it depend upon whether, as in your patient, it depends upon whether the CHADS-2 score is elevated or not. And this is the information from the trial looking at the all patients, Watchman versus control, CHADS-2 1 score, CHADS-2 greater than 1 score. The relative risk in terms of primary efficacy was very similar, meaning that indeed this device works in patients who are at higher risk as well as that group of patients who were at lower risk for the composite endpoint of stroke, cardiovascular death, or systemic embolism. You might say, well, we've talked about the fact that older patients have more problems. Does the device work in older patients or just younger patients? This is that data broken down in this particular case by patients less than 73 and greater than 73. And if you were to look at the relative risk, it is very similar. So in those patients who received this device, it doesn't matter whether they received it when they were 60 or when they were 80. It works equivalently well, irrespective of the CHADS-2 score or the age of the patient. Final one is to say, you're an interventional cardiologist. There are some electrophysiologists around that may also be interested in technology like this. I don't like to show this slide just because of the fact that electrophysiology looked somewhat better, just a little bit better, but somewhat better. If you were to look at implantation success, it doesn't matter whether you're an electrophysiologist or an interventional cardiologist. You can do this safely if you are experienced in the left atrial appendage working. Final piece of information is to say, well, if you want to avoid long-term warfarin therapy, patients want to avoid it, you want to avoid it, is it going to work? In this particular study, we can see after 24 months, 95% of the patients can get off of warfarin therapy. So if that is your goal and the goal of the patient to get off warfarin therapy, a device such as this indeed works to achieve that goal. What then could we say? The hypothesis that in patients with non-valvular atrial fibrillation that stroke results from thrombus in the left atrial appendage is correct. We have confirmed that. The second is the benefit of left atrial appendage occlusion remains stable. The third is that 90% of patients can be taken off of warfarin without harm. We can learn that the left atrial appendage is indeed, as you have thought, fragile. The landscape is unforgiving. With the change in technology and change in experience of the operators, we can minimize that and the safety will improve. Long term, the risk of device embolization is very low in this group of patients. And it doesn't matter whether you're a card-carrying electrophysiologist or interventional cardiologist. Indeed, the device works. And so what could we conclude? The field is a very fertile one for device technology advancement. But it looks like these devices will play an enormously important role in the treatment of patients with non-valvular atrial fibrillation at risk for stroke.
That's fascinating. The field really is moving very, very quickly. Just in the last few minutes here, I really have just three questions related to the Watchman device. Number one, what's the fate of the device? Does it get endothelialized? What happens to it fundamentally, and does that affect the thrombotic risk with a piece of hardware in there? The second question is, did it actually meet the non-inferiority criteria? And if so, the third question is, where are we with approval of the device?
In terms of endothelialization, there is relatively limited data from the human experience. You want that to be the case. You don't want to have many of these devices removed to see whether they're endothelial or not. In the animal laboratory setting, it takes probably a month or month and a half to endothelialize. At the end of that time, it's endothelialized. In a couple of patients who have died typically of non-cardiac causes, we always say that happened to be the case in this particular situation, at variable times after implant, they were fully endothelialized. There, however, have been some patients in whom there's been thrombus developed around the device. It's been seen, it's uncommon. Nobody knows exactly why that is, whether that's incomplete endothelialization or whether that's a pit that was uncovered or a lobe that was uncovered. That's the first piece of information. The second piece of information results from the regulatory issue standpoint and the non-inferiority. It met non-inferiority. And indeed, the further we go out, it becomes closer towards being superior because all of the adverse events are up front in terms of pericardial effusion. So it met non-inferiority criteria that the FDA approved. And as we go further out, it looks like it's getting closer towards being superior. The third piece of information is to say, well, if that's the case, what's wrong with the FDA? The FDA is still concerned, as they should be, about the safety of these devices, and indeed they want more data. So there will probably be an add-on trial. They are most interested in the group of patients who cannot take warfarin at all. We don't have very much data in that group of patients. But in this group of patients who can take warfarin, they're going to then randomize a few more of those patients, that is to say about 200 more of those patients, to look at the continued safety and efficacy as well as the rollout to different centers than the original pilot study.
That's fantastic. So lots more to come with this device and lots more to come in the field of atrial fibrillation.
Right.
My guest faculty today has been Dr. David Holmes from the Mayo Clinic. Dr. Holmes, thanks again for joining us and for such a fascinating presentation.
Great to be here, Sunil. Have a great day.
Until next time, then, from all of us here at Duke, this is Sunil Rao saying thanks for joining us and take care.